Committee on Health, Education, Labor, and Pensions will please come to order. Let me just apologize. I'm smiling because we're in a rental car. The young man driving me is in a rental. And he goes, I'm pretty sure we have enough gas to get to LaPlace. And that's just before he's pulling off on the side of the road when clearly we did not have enough gasoline to get to LaPlace. But thank you for bearing the fact that we're late, that I'm late. If I'm in a crowd and I'm speaking to whatever crowd I'm speaking to, and I say everyone knows in their family or among their friends someone who's having an issue with serious mental illness, and people's a person's face becomes serious, and they nod. And it's not something we speak about generally, but it's something that we all deal with personally. And we're at a time when folks are more connected theoretically than ever, and yet more isolated than ever. And when you're more isolated, you tend to have less support. You tend to be more depressed. Suicide, one of the leading causes of death for teens and young adults. We had a committee hearing yesterday at LSU, and the young lady who was
recording in progress
for Tiger TV asked a really pertinent question about mental illness. And when I responded by saying, in your age group, that's one of the leading causes of death, she nods her head. This is a reality. 1 in 5 adults experience mental illness. More than half don't get treatment. And of course, these are not statistics. They are our family. They are our friends. Now, we've made progress. The landmark 21st Century Cures Act included major mental health reforms that I championed. I say I because there was an input from our communities, including some of those who are on the board here, on the panel here. The legislation coordinated fragmented mental health resources across the federal government, providing resources to address serious mental illness, strengthen mental health parity, and provided support for mental health courts and crisis intervention teams. I led a bipartisan renewal effort of that law, which supported the uptake of evidence-based collaborative care models and crisis supports. Now, I practiced medicine for 25 years in the Louisiana Charity Hospital system, and I don't have to tell you that mental health and physical health is linked. If someone feels good about themselves, they're more likely to be intentional in how they take care of their physical health. If the physical health deteriorates, it can lead to issues of depression and otherwise. Now, substance use disorders impact goes well beyond the patient. Tanja Miles, I'm such an admirer of her because she has walked the talk in terms of how do you support a family, a community, as they in turn interact with their workplace and society. The SUPPORT Act, which was a bill that I helped author that President Trump recently signed into law, helps curb the devastation by bolstering prevention, treatment, and recovery services. And I led the law's reauthorization to build on those reforms. And it provides guidance to the states about how to target block grant dollars to help those in most serious needs. Drug overdoses, largely led by fentanyl and other synthetic opioids, are the leading cause of death for young adults from 18 to 45. From 2022 to 2024, U.S. Customs and Border Protection seized record amounts of fentanyl, nearly 50,000 pounds, more than enough to produce 2 billion lethal doses. I thank President Trump for signing my Halt Fentanyl Act, which gives law enforcement more tools to push against the cartels bringing in fentanyl, protecting Americans from fentanyl-related substances. But it's not just about stopping the drug dealers. It's about supporting people dealing with their illness and putting them on the road to recovery. So let's treat every wound, both visible and invisible. I thank our witnesses for being here, for their commitment to improving treatment for mental health and substance use disorders. And with that, I'll introduce them to provide their testimony. First is Art Kleinschmidt, a native New Orleanian, formerly served as the acting assistant secretary for SAMHSA under President Trump I. He has over 2 decades of experience providing direct services for mental health, addiction, and co-occurring disorders, and he's also shared his personal recovery story. Dr. Kleinschmidt holds an MBA and PhD and is a licensed professional counselor. And thank you, sir, for joining us.
Thank you for having me.
I think they'll turn on your microphone.
Can you hear me?
Gotcha.
Well, good morning, Chairman Cassidy. Thank you for the opportunity to testify today on this very important topic. I also want to extend a special thank you for your support for SAMHSA's elimination of hepatitis C pilot program. We are invited here today by the committee to explore strategy and care models that effectively address mental health and substance use disorders. I am grateful that Senator Kennedy is shining a light on this topic. Despite our progress, the latest provisional CDC overdose death numbers indicate that approximately 70,000 people died from a drug overdose in 2025. This equates to more than 194 people dying from an overdose each day. In addition to drugs, the CDC also reported that approximately 170,000 people die from excessive alcohol consumption annually. Put succinctly, addiction kills, which is why making effective models of care available to those struggling is critical. Through the grace of God and support of my family and others, I have over 24 years of continuous sobriety. The last few years of my alcohol and drug use were actually the beginning of the opioid crisis as pill mills populated my hometown of New Orleans, Louisiana. I am also the former acting assistant secretary of SAMHSA, served on the White House Domestic Policy Council as a subject matter expert on mental health and addiction, and was appointed by President Trump as the Deputy Director of the White House Office of National Drug Control Policy in the last term. I'm also a licensed mental health professional with more than 20 years of experience in working across all levels of care and throughout the socioeconomic spectrum. I'll focus my remarks on intervention and treatment strategies that work, but an equally important question is what hasn't worked. Harm reduction in the past has been a valid component in addiction treatment, but this concept was subverted by the Biden administration. Their approach to addiction treatment under the guise of harm reduction included taxpayer-funded crack pipes, safe injection sites, and billboards telling people to feel empowered they were using fentanyl safely. This only encouraged more self-destructive behavior. The Trump administration has worked hard to bring sobriety and the miracle of recovery to all Americans. As such, during my time at SAMHSA, we spearheaded the effort to classify naloxone as a life-saving intervention as opposed to just another tool of harm reduction. We also modified notice of funding opportunities to promote sobriety, recovery, and self-sufficiency. In my professional opinion, all individuals suffering with a severe substance use disorder are confronted with a potentially fatal condition. As such, these people are in a crisis situation. It is not enough for the federal government to continually discuss creating greater access to care. We need to adapt an intervention system that moves people from active addiction and mental illness into treatment. Hepatitis C is a chronic and communicable disease that adversely affects the homeless population and individuals with a substance use disorder. SAMHSA's Hepatitis C initiative funded 19 treatment centers in 2025, including Odyssey House in New Orleans, to provide necessary medical treatment. The medical care for hepatitis C may bring a client to treatment, which will encourage them to complete a continuum of care of addiction and mental illness treatment. Through my discussion with civic leaders from Baton Rouge, New Orleans, Los Angeles, and Kensington, Philadelphia, the message is clear. They are frustrated as the same people repeatedly receive crisis care and end up back on the streets. This is an example of insanity as we continue to do the same thing over and over and expect a different result. Kensington is one of America's hardest hit neighborhoods by the scourge of drug addiction. I visited Kensington to work with civic leaders and community nonprofits. We established a certified community behavioral health center in the heart of this community that will treat a severely afflicted population. It is my belief that we can fortify a link between CCBHCs and sober living residences to create a new model of care. Furthermore, we need to view law enforcement contact as another point of intervention for individuals. In addition to problem-solving courts like drug courts and assistive outpatient treatment, peers can be very effective in bringing recovery to people in the criminal justice system. By training and pairing a peer with law enforcement agencies, you can ensure there is someone to encourage individuals at this crucial time to remain in an effective treatment program. Peers are also successful and utilized in street outreach programs, emergency rooms, and have a great utility to the community. Also, the Trump administration places a great emphasis on faith-based programs, which is something I fully support. Many of my clients are plagued by their inability to delay gratification, which has caused numerous consequences in their lives. It is faith that allows somebody to replace instant gratification of drug and alcohol abuse with the belief that more meaningful goals are achievable and ultimately more rewarding. Further, for 20 years, I have worked with many people who are robbed of basic life skills. Despite these hardships, people break free from the chains of addiction each day and learn to work one day at a time to create a whole new life for themselves, which includes the reparation of relationships, the establishment of meaningful work, and giving back to service, all of which form the foundation of spirituality. There is no quick fix for addiction and mental health disorders. Panels like these and people like you who believe that making the miracle of recovery a reality, we can recoup the opportunity costs caused by addiction and witness real people living fulfilling lives. Thank you for your time, and I look forward to your questions.
Thank you, sir. Next, we'll go to Lonnie Grenier, Policy and Advocacy Manager for the Odyssey House, Louisiana. He has supported the good work of Odyssey House, providing mental health and substance use disorder treatment and related services. Mr. Grenier has dedicated his work to reducing demand for illicit drugs while helping to expand access to treatment for folks here in Louisiana. He's a graduate of LSU. Thank you, sir.
Good morning. Thank you, Chairman Cassidy. Distinguished colleagues and friends, thank you for the opportunity to be here this morning and to speak about the importance of a full continuum of care in addressing substance use disorder, serious mental illness, and co-occurring disorders. As mentioned, I represent Odyssey House, Louisiana, which is a nonprofit health and human services provider with a comprehensive continuum of care that includes prevention, treatment, primary and behavioral health care, housing, homelessness response, and recovery support services. For more than 50 years, we've served individuals across Louisiana with approximately 14,000 unduplicated individuals served each year across our continuum. I'm tremendously honored to be included on this panel among such renowned experts and leaders in the behavioral health field, and I appreciate the opportunity to offer perspective to the committee on such an important societal issue as building strong continuums of care, supporting treatment and recovery. At its core, a continuum of care recognizes a simple but critical truth. Recovery is not a single event, it is a process. It requires stabilization, treatment, and long-term reintegration in the community. And it requires that systems are built to support individuals at every stage of this process. A truly robust continuum includes prevention, early intervention, overdose and infectious disease reduction, detox, residential and outpatient treatment, medication-assisted treatment, primary and behavioral health care, recovery housing, vocational resources, and long-term support. Not every individual will need every level of care or piece of the service array, but every individual benefits from access to a coordinated system that can meet them where they are and adjust as their needs evolve. This is especially important for individuals with co-occurring substance use and mental health conditions. When care is fragmented, people fall through the cracks, but when care is integrated, outcomes improve. An example of this is how Odyssey House, Louisiana has innovatively crafted its continuum to address whole person health. By evolving beyond our origins as a residential addiction treatment provider and establishing federally qualified health center locations on site with our residential programs, we're able to address individuals' primary care, behavioral health, and MAT needs on site, all in an integrated fashion. This model is enhanced by Odyssey House's 340B pharmacy program, which provides prescription medication to our client population at a deeply reduced rate. And, as mentioned, OHL was one of only a few providers nationally recently awarded a SAMHSA grant to test and treat hepatitis C amongst people with substance use disorders who are experiencing chronic homelessness. As we are also operators of the 296-bed low-barrier homeless shelter funded by the City of New Orleans, OHL is eager and uniquely equipped to leverage this grant funding to help better address whole person health needs of the individuals that we serve, targeting an infectious disease which bears tremendous costs to our shared public health systems. Yet just as important as what occurs in and around recovery environments is what happens beyond clinical treatment. Recovery is sustained not only by medical care, but by stability, stable housing, employment, connection to care, and supportive community networks. When these elements are in place, we see reductions in recidivism, fewer emergency system encounters, and stronger long-term outcomes. In other words, a true continuum of care is grounded in whole person health. It recognizes that individuals often present with complex medical needs such as chronic medical conditions, mental illness, housing instability, and justice system involvement, and that addressing substance use and isolation is not enough to produce lasting recovery. Emphasis on access and retention are equally critical areas of focus in creating a strong continuum. We know that the window when someone is ready to seek treatment can be very narrow. If care is not available at that moment, the opportunity is often lost. That's why low-barrier, responsive models of care are so important. Models that offer rapid access to treatment and minimize administrative hurdles and actively engage individuals where they are. But access alone is not enough. We must remember that retention in care is what drives outcomes. Our strong belief is that the individual level of care should meet the individual level of need for as long as need be. And research consistently shows that longer treatment engagement leads to better results pertaining to long-term recovery. Yet individuals often disengage due to competing survival needs, instability in housing, untreated mental health conditions, insufficient lengths of stay, or disruptions as they move between levels of care. To address this, our systems must prioritize creating long-term treatment environments within their own organizations, continuity by ensuring warm handoffs between providers, aligning services across sectors, and supporting individuals' engagement through each transition in their recovery journey. The stakes in this fight, Senator, are both economic and societal. Untreated substance use disorder and mental illness drive significant costs across healthcare, criminal justice, and social service systems. The U.S. Surgeon General's landmark report on addiction found that every dollar invested in effective treatment yields approximately $11 in savings through reduced crime, lower incarceration costs, reduced hospitalizations, and increased employment earnings. Similarly, a 2025 economic impact study capturing Odyssey House's economic and societal impact underscores that in our fiscal year 2024 budget, we generated $67.1 million in economic impact and provided $341.2 million in cost savings associated with chronic addiction. Finally, none of this is possible without stable and sustainable funding. Federal investments, particularly through Medicaid and programs administered by SAMHSA, are foundational to maintaining the continuity of care. When funding is disrupted, even temporarily, it creates real consequences in service reductions, workforce instability, and reduced access for individuals who need care most. Looking ahead, we would urge Congress and the Trump administration to prioritize continuity in funding, flexibility in how services are delivered, and policies that expand access, especially for individuals who fall outside of traditional coverage systems. And this is particularly important amid the growing populations of under and uninsured individuals with states enacting the Medicaid provisions of H.R. 1. We would also urge continued support for SAMHSA as its own single entity, as we are concerned that consolidation with other agencies, with other focus areas, could dilute our national response to public health crises of mental illness and addiction. In closing, thank you again, Senator, for your leadership and your commitment to this issue. I look forward to continuing to work in partnership with you to strengthen our behavioral health treatment systems and improve outcomes for the individuals and the communities that we collectively serve. Thank you.
Thank you. Next, we're joined by Tanja Miles, CEO of Set Free Indeed Ministry, which takes a faith-based approach to addressing mental health and substance use disorders. She has testified before Congress on mental health policy reform and has worked alongside federal agencies to address the opioid crisis, has led national campaigns raising awareness about fentanyl overdoses, suicide prevention, and crisis intervention. She's also a certified peer support specialist. Thank you for being here, Ms. Miles.
Thank you so much, Chairman Cassidy and members of the committee. My name is Tanja Miles, and I'm CEO of Set Free Indeed Ministry based in Baton Rouge, Louisiana, and Senior Advisor for Awareness, Partnerships, and Community Engagements for the Huntsman Mental Health Foundation based in Salt Lake City, Utah. I'm a certified peer support specialist. I currently serve in the Louisiana National Guard and have served in the Louisiana Army National Guard for 9 years as a military police. I'm a licensed and ordained minister and pastor, a subject matter expert in mental health, substance abuse, and suicide prevention. I have been in recovery for over 36 years, and I'm a 3-time suicide attempt survivor. Both my parents struggled with alcoholism and had 20 years of sobriety before they died. I have experienced the whole crisis continuum between myself and my immediate family members. I know firsthand when crisis work and when it does not. In 1999, my husband and I started Set Free Indeed Ministry, a faith-based nonprofit that helps individuals and families who are struggling with addiction and destructive behavior. Our compassionate and supportive approach to addressing addiction, including providing individual and group peer-led groups. We are also community-based outreach across East Baton Rouge Parish and has brought treatment and recovery resources to people across the city. Today, we have a team of 14 peer support specialists, mental health professionals, addressing the fentanyl crisis in our community. Our efforts in East Baton Rouge Parish led to the largest decrease in drug overdose deaths in the state. This reduction is among the best in the country. Thank you to Senator Cassidy and President Trump for the Halt Fentanyl Act and for the Support Act. They are indeed saving lives. I see it firsthand. I can't thank you enough. In 2004, I founded Free Indeed Treatment Center. It was Louisiana's first licensed faith-based outpatient treatment center and the first of its kind in the nation. Free Indeed provided intensive outpatient treatment, support recovery service for individuals. The model moved many people to wellness and to recovery and helped to start faith-based treatments like Free Indeed across the country. I worked alongside Dr. Jan Kosowski to bring Baton Rouge, Louisiana's first stabilization center, and was the founding board member of the Bridge Center for Hope in Baton Rouge, Louisiana. The Bridge Center for Hope provides compassionate immediate crisis care for those experiencing mental health and a substance abuse crisis. No matter what the situation is, individuals will never be turned away. The Bridge Center for Hope is open 24 hours, 7 days a week, serving individuals 18 and older from across East Baton Rouge Parish and beyond. In my role as the senior advisor for the Huntsman Mental Health Foundation, I support their goals into uplifting individuals and families. The Huntsman family has been advocates for both civic service and courageous philanthropy. The Huntsman Family Foundation was created by the legacy of John and Karen Huntsman. The foundation focused primarily on study treatment and eradicating cancer, as well as providing hope and healing to those suffering from mental health and substance abuse. They provide housing, domestic violence mitigation, scholarships, educations, and that is the priority of the foundation. Mental health and substance abuse challenges do not discriminate. From the curbside to the country club, it can affect anyone. Losing their sister Karen to a drug overdose after years of suffering from depression, eating disorder, and substance use disorder motivate the Huntsman siblings on mental health research, treatment, and policy innovation. This led to the creation of the Huntsman Mental Health Institute at the University of Utah and complements the groundbreaking Huntsman Cancer Institute. They have the whole crisis continuum. Together, these institutes strive for continuous breakthroughs in helping relieve human suffering. It is with the Huntsman's sole commitment to making an impact in the heart of everyone who comes through their doors. I'm grateful to be a part of their organization. I and many other behavioral health community specialists, like here on this panel, we're grateful to you. And we're grateful to President Trump for signing the National Hotline Designated Act in 2020, creating 988 Suicide and Crisis Line. We are equally grateful to Congress for its continual bipartisan support in advancing this critical work. Millions of Americans in America suffer from addiction and destructive behavior. We heard that earlier. In 2020, SAMHSA, under President Trump's leadership, worked in partnership with providers, peer support specialists, advocates, and people with lived experience like me to define the function of crisis systems that we're talking about today. It should be someone to talk to, someone to respond, a safe place for help, and someone to follow up. This model already working in communities that has implemented it. The challenges before is not whether what we know what to do. The challenge is whether we have fully built to sustain it. As we move towards this vision, there is clear and acceptable actions that Congress can take to make this happen. inclusion of crisis care centers and essential health benefits, Congress should require Medicaid and Medicare and commercial health plans to recognize and cover core crisis care services as an essential health benefit. These services include crisis mobile teams, crisis receiving centers, crisis stabilization centers. These services align directly with existing and essential health benefits categories including emergency service, mental health and substance use disorder, and hospitalization. Yet today, coverage and reimbursements remain inconsistent and inadequate. When crisis services are not covered, the cost does not disappear, it shifts. It shifts to state and local government, law enforcement and first responders, emergency departments, and ultimately to individuals and families who are suffering. Most communities do not have the financial capacity to subsidize these services. As a result, taxpayers fund a most expensive and less effective system. Crisis care work, it reduces overall cost systems. These outcomes are not only benefit for individuals, they are significantly more cost-effective than defaulting to hospitals or law enforcement response, meaning people end up in our local jails. And local jails are not adequate to treat a lot of people who are suffering from mental health and substance use disorder. Although SAMHSA has recently published Marlowe's crisis service definition to guide both service and delivery reimbursement expectations, these standards have not yet translated into a consistent or adequate payment structure. As a result, crisis providers are being asked to deliver 24/7 availability, rapid community-based response, clinically approach, and multidisciplinary care. But or reimbursement at rates they fall below the actual cost of delivering these services. In effect, we are asking crisis systems to operate like emergency medical services and hospital departments without funding them like essential emergency care. Congress should direct the Center for Medicare and Medicaid to establish clear guidelines and benchmark that aligns reimbursement with the true cost of care. This includes establishing sustainable reimbursement framework, ensuring rates that are effective and efficient, and also strategizing state ownership of 988 crisis response. However, we know that there's a growing alignment between funds and the systems and who control it. In most states, these investments represent the vast majority of total crisis funding, with federal contributions covering only a fraction of the cost. At the same time, the current structure requires local centers to operate under direct contractual relationships with national administrative, including operation, and these do not align with the state funding systems prior to this requirement. Congress should authorize a state optional model that allows state to assume a more direct leadership in the role of 988 implementation while maintaining national standards across quality and responses. In my closing, in crisis care, the difference between a call and a response can make the difference between hope and harm. Thank you for this opportunity to testify. I look forward to working with this committee to advance these priorities and to meet this moment with urgencies and in demands. Thank you.
Thank you for a very thoughtful and detailed testimony. Next is Nick Richard, Executive Director of NAMI, the National Alliance on Mental Illness in Southeast Louisiana. And Mr. Richard helps bridge the gaps between law enforcement, mental health providers, and community leaders to address the mental health crisis. He helped found the 22nd Judicial District Behavioral Health Court and the Crisis Intervention Team, the CIT program within the St. Tammany Parish Sheriff's Office. He's a graduate of Huntington College and is also a certified Crisis Intervention Team Coordinator. Thank you, Mr. Richard.
Thank you. Oh, am I on? Yeah, I'm on. There you go. I don't know who I got in trouble with to go after Tanja, but next time put me a different part of the lineup because I've watched her speak quite a few times and I'm always impressed with everything you have to say. So thank you, Chairman, for allowing me to be here today and for allowing me to make some remarks. I'm here today to share the perspective of NAMI Southeast Louisiana along with the voices of the individuals and families we serve every day. As stated, my name is Nick Richard, and I serve as the Executive Director of NAMI Southeast Louisiana. NAMI is the National Alliance on Mental Illness, and it's the nation's largest grassroots mental health organization. NAMI-SELA focuses on providing free education, peer support, advocacy, direct services, and housing to individuals living with mental illness and their families across Southeast Louisiana. We are on the front lines of a system that is both deeply committed and deeply strained. We see the successes, we see the progress, but we also see very clearly where the system is falling short. I want to do something that we normally don't do when we're advocating. I actually want to highlight the positives that we have here. And the first positive is, and this is something that should be celebrated, is we have the leading senator in healthcare from Louisiana. That is something that we've not been able to say in this state in my lifetime. So I thank you, Senator Cassidy, for leading and doing what you're doing. And also, the honor of having a field hearing here is something that I know doesn't happen a lot, and that is something to be celebrated for the individuals who live in Louisiana. To have this committee here and to have this hearing here in our state is something that should be celebrated, and that is a success and that is a win. So thank you for that. Louisiana has also made meaningful investments in community-based behavioral health over the past decade. We've expanded managed care, strengthened community mental health centers, and increased the use of peer support. We've also seen growth in programs like behavioral health courts, drug courts, crisis intervention training that are making real difference. In many parishes, law enforcement officers are better equipped to respond to mental health crisis, and we're seeing more individuals diverted away from jail and into care because of that. At NAMI, we see individuals stabilize, reconnect with their families, and begin recovery. We see it in our peer support groups, where someone with lived experience guides another person through their darkest moments. We see it in our supportive housing, where a person who was once cycling through emergency rooms and jails now has a stable plan. We see it in our transportation program, where removing the barrier of a missed ride means someone actually makes it to their appointment. Those successes are real and they matter. But the reality on the ground tells us we have a long way to go. As previously stated, in Louisiana, approximately 1 in 5 adults experience a mental health condition, yet more than half do not receive treatment. Louisiana consistently ranks near the bottom nationally in access to mental health care. We have fewer than half the psychiatrists per capita needed to meet demand, particularly in rural and underserved areas. At the same time, the need continues to grow. Louisiana has historically had one of the highest overdose rates in the country, and through some of the work here, I know that that is improving. And suicide remains a leading cause of death in many of our age groups. But behind every one of those numbers is a person, and behind that person is a family. In my role, I've sat across from mothers and fathers who have lost their children. I've sat with individuals who've lost their spouses, their brothers, and their sisters. Those conversations stay with you. They're the reason we do this work, and they are the reason we do not stop. And they are the reason we continue to push for real change and true parity in how we treat mental health. Because for too long, mental health has not been treated the same as physical health, and people are paying for that with their lives. One of the most significant gaps we see is access to timely, appropriate care. In many parts of Southeast Louisiana and throughout the country, individuals in crisis still end up in emergency rooms or jails because there's nowhere else for them to go. Emergency departments are not designed for long-term psychiatric care, yet people often wait hours, sometimes days, for placement. At the same time, we do not have enough inpatient beds and, more importantly, step-down options to meet the demand. And when individuals are discharged, too many are released without stable housing. And I want to be real clear, supportive housing is health care. At NAMI Southeast Louisiana, we operate supportive housing programs, and we can tell you directly that when individuals have stable housing paired with services, case management, peer coaching, transportation appointments, connection to employment, hospitalizations go down, incarceration goes down, and quality of life improves. But the demand for supportive housing far exceeds the supply. We continue to see individuals discharged from hospitals and correctional facilities back into homelessness, which almost guarantees they will cycle back through the system. This is not a failure of the individual, this is a failure of the system. Workforce is another major challenge. We do not have enough psychiatrists, therapists, case managers, and peer support specialists to meet the need. Providers are stretched thin, and burnout is real. If we want a functioning system, we must invest in the people delivering the care. We also need to be very intentional about how we respond to individuals with mental illness who intersect with the criminal justice system. Too often, individuals with serious mental illness, particularly those experiencing homelessness, are drawn deeper into the system rather than diverted away from it. From our perspective, expanding court involvement is not the solution. We know what works. When paired with proper services, diversion programs work, behavioral health courts work, crisis intervention training works, peer support works, and supportive housing models work. At NAMI Southeast Louisiana, we're doing all of these right now in this region with results that we can show. We should be building on those strategies, not replacing them with more complex judicial processes. Finally, coordination remains one of our biggest opportunities. We have strong providers, strong programs, like many of the people here on this panel, and committed partners across Louisiana, but too often these systems operate in silos. Individuals and families are left trying to navigate healthcare, housing, and social services on their own, often during moments of crisis. We can do better and we must do better. In closing, I'd like to offer a few priorities. Continue investing in community-based mental health services, especially crisis response and outpatient care. Expand supportive housing and recognize it as a core part of treatment. Strengthen the behavioral health workforce. Prioritize diversion and community-based solutions over deeper involvement in the criminal justice system. And finally, and most importantly, ensure true mental health parity, so mental health is treated with the same urgency and resources as physical health. At NAMI Southeast Louisiana, we remain committed to this work every day. Through our peer support, our housing, our transportation, our education programs, and our diversion partnerships, we're showing what is possible when communities invest in real care. We carry the stories of the people and families we serve with us. We will continue advocating until the system reflects the level of care, dignity, and urgency that they deserve. Remember, there is no health without mental health. Thank you for your time. I look forward to your questions.
Thank you. Somehow, I think we're about to hear a little bit about the importance of parity in mental health and physical health and each is built upon the other, each testimony. Next is Stuart Archer, CEO of Oceans Healthcare, providing inpatient and outpatient mental health and substance use disorder treatment services across Louisiana and 8 other states. Mr. Archer has more than 2 decades of experience in the post-acute care and the behavioral health sectors. He's a graduate of Northwestern State University with an MBA from LSU. Thank you, Mr. Archer.
Chairman Cassidy, thank you for the opportunity to be here.
Can you pull that microphone a little bit to you?
Let's see. How's that? Can you guys hear me?
Mejor.
Good? Yep.
Thank you.
Chairman Cassidy, thank you for the opportunity to be here today and lend our voice with our esteemed colleagues. As mentioned, my name is Stuart Archer, and I'm honored to serve as the Chief Executive Officer of Oceans Healthcare. Founded in rural Louisiana over 20 years ago, Oceans today operates over 48 psychiatric hospitals and outpatient behavioral health locations across 9 states, serving adolescents, adults, and older adults with serious and complex psychiatric needs. Much of our work takes place in rural and underserved communities where we are often the only behavioral health provider available to these communities. Each year, our team of over 4,000 caregivers support more than 57,000 patient admissions, provide approximately 450,000 patient days of care, and deliver over 700,000 therapeutic interventions. Many of our patients we serve rely on Medicare or Medicaid, coming to us through emergency departments, law enforcement, or court order commitments. In many of these communities, expanding access requires partnership, often through innovative joint ventures with local nonprofit health systems such as Ochsner here in Louisiana to bring needed behavioral health capacity closer to patients. This is not theoretical for us. It is what we see every day in our hospitals. Ocean's role is to provide clinically appropriate treatment and stabilization until patients are ready to safely step down into community-based outpatient care and continue their recovery as part of their everyday lives. You know, common sense tells us that when medicine changes, policy needs to change with it. In behavioral health, unfortunately, that has not always happened, as many of my peers have shared as well. You know, over time, our understanding of mental illness has evolved, but policy has not always kept pace. This is due in part to the complexity of psychiatric illness, which does not fit neatly into the traditional healthcare structure. And unfortunately, when something is uncomfortable, it can be easier for older policies to remain in place even as the system around them evolves. This is, for instance, what we're seeing with the Medicare 190-day limit on inpatient psychiatric care. Imagine if Medicare placed a lifetime cap on hospital care for cancer or heart disease or diabetes. We would immediately recognize this as not only immoral, but as inconsistent with how illness works. This arcane policy is one of many that date back to a time when behavioral health care was understood and delivered very differently. Today, we understand that severe mental illness can both be chronic and episodic. Patients may stabilize, return to their communities, and later may require acute hospital-level care again. That is the nature of illness, not a failure of a patient or a system or a caregiver. A lifetime cap does not reflect that reality. Instead, it places additional strain on communities and limits our ability to care for people when they need it most. MedPAC has found that at any one given time, approximately 50,000 Medicare beneficiaries are at or near this limit. These are often the most vulnerable individuals in our healthcare system, and when that limit is reached, the need for care does not disappear. The illness is still there, the risk is still there, and the family is still in need. But instead of being met in a psychiatric care setting, this need is often pushed somewhere else. It shows up in emergency departments, it shows up in law enforcement, it shows up in homes where families are trying to manage their crisis they can't safely navigate many times themselves. This is not access, this is not care, this is a system waiting until crisis gets worse. Chairman Cassidy, I want to thank you for your leadership on this issue. Oceans Healthcare strongly supports the important work you're doing to remove this limit to ensure that individuals and their families can access the care they need for as long as they may need, and not just for as long as a faceless system deems enough. When we deny the right setting for care, we should not be surprised when people end up in the wrong one. And this is not the only situation where outdated policy creates barriers. In our facilities, we care for patients who come to us voluntarily, but many who do not. They arrive through emergency departments, law enforcement, and court-ordered commitments. These are individuals in acute crisis, often without the ability to advocate for themselves. But yet, even in these situations, Medicare Advantage plans can impose higher cost sharing and more restrictive authorization requirements than traditional Medicare. This creates additional barriers for care for patients, families, and providers working to deliver the basic necessary care. More broadly, we continue to operate as IMD hospitals under structural barriers that include uneven parity enforcement and long-standing policies like the IMD exclusion that limit access to appropriate care. And I'd like to highlight an issue directly, and many of these policies, interestingly enough, date back to the Kennedy administration, some before even someone landed on the moon. So we're dealing with some of these policies that are just decades old. I'd like to also highlight an issue directly within the committee's jurisdiction. Today, private behavioral health providers like Oceans cannot work directly with SAMHSA to access mental health care block grants. In underserved regions where Oceans may be the only behavioral health provider, that means federal dollars that could make a meaningful difference can't be activated directly to support the families and patients who need care. During a psychiatric crisis, patients and families don't care about tax status. They need access to life-changing and life-saving care. This restriction was removed for private substance abuse providers, but has yet to be addressed for behavioral health providers like Oceans. And to be fair, our providers are not asking for any separate funding or special treatment, simply for the ability to be considered for these funds alongside other providers. Allowing these providers to compete directly for these funds would help expand capacity, improve access for patients who need it. Chairman Cassidy, your work on the 190-day limit reflects a broader opportunity to highlight how outdated parts of the regulatory framework are, many of which were enacted in previous administrations and make little sense in today's world. We have the ability to take policies that were built for a different time and bring them into alignment with how care is actually delivered today. Eliminating the 190-day limit is an important step in improving access to resources that support care delivery is another. Thank you for the opportunity to be here today, and I look forward to your questions.
Thank you all. Now, by the way, normally, if we're in D.C., you would be sitting down there, and I'd be up here with the whole dais of fellow senators prepared to ask questions. I actually like this because we're all up here. So when I'm through, I may ask you to ask questions of each other, because what you're saying reinforces what the other is saying, but it also, sometimes there's a little bit of a tension. I've got a fellow that used to work at SAMHSA, and a fellow is saying that SAMHSA regulations keep him from receiving the grants when he is the only mental health provider in a community. So that'll be kind of, I'm going to ask you all to address that. And if you will, try and channel, we are being live streamed, and there's people who cannot be here who have a personal connection to these issues. And so again, try and speak to not just the audience, but the people in the live stream. Now, we all know what I'm about to say, but in your answers, I'm going to ask that you kind of parse it out. There is a difference between addiction, there's a difference between serious mental illness, and sometimes there's not, because someone is co-diagnosed. They have both addiction and serious mental illness. So as you speak to these issues, and as you speak to the live stream and to the audience, make sure that you help us understand what you're speaking to, because we're here for solutions. Now, I'm going to start with, I can start with any of you. Art.
Yes, sir.
Stewart says, let me start over. Tanja, you mentioned that there's a problem with workforce. Nick mentioned that as well. The rural areas being particularly poorly served. By the way, one reason my medical practice was in the charity hospital system with people who were uninsured. And they would drive from across the state to come see me because I was the only liver doctor. Hepatitis C is a big thing I used to address. One of the visions I had behind the Infrastructure Investment and Jobs Act, which the Trump administration has just released $1.35 billion to make sure that everyone has access in our state to high-speed affordable internet, is that you could do telemental health. The VA is already doing this, either through an iPad given to the vet when he or she is at home, or they would go to a pharmacy and go into a room in the back and have the interview. So to what degree, I'll start with you, Nick, to what degree can telemental health, when truly everyone has access to high-speed affordable internet, address the concern of a mom whose child has a mental health issue, and the only pediatric psychiatrist, they only live in Shreveport, Baton Rouge, Lafayette, and New Orleans? How effectively can telemental health address these issues?
Thank you, sir, for that question. And I think the answer is simpler than it needs to be, right? So, yeah, I do believe in integrating access to virtual mental health care, but coupled with that, we need to bolster up our peer support specialists, our case managers, and that's where I believe we're missing the boat. We have seen, obviously, through COVID, a dramatic increase in telehealth, especially through psychiatric care. But again, we're human beings. We need people. So investing in peer support specialists and investing in expanding case management in those particular arenas is going to get it, because, seeing a doctor is great, right? But what happens after that, right? What happens with all the other things? Mm-hmm. I take these phone calls from parents, the exact phone calls that you're talking about, in rural areas where they have no help. And if I can get them a telehealth appointment, that's great. But what then? So we really need to invest into incentivizing individuals and really growing more of these programs that are not medical programs. Peer support, again, family support, and case management is really where the answer is there.
So Tanja, I don't know this, I'm asking you. For addiction services, does tele-addiction services work? Does the peer support have to be in person? Can it be online? Tell me, please.
I think it could be both. I mean,
Please pull that microphone to you.
I think it can be both, because what has to happen is crisis need connections. And, like Nick was saying, there's a lot of people who just don't have access. Look, not just in rural areas, just in regular cities across the state, don't have access to it. They might live in a zip code where they can't get to another place. So having that in place would be something that was just so needed, where they can go online. Like you said, everyone has a phone, and they can connect with a therapist, with a psychiatrist, but also with a peer support specialist. Again, we have to have these all things in concert, because I think a lot of times we think if we have this is great. But if we're talking about crisis continuum, there's a continuation of that. And look, I can't stress enough, we talk about workforce. We know there's a workforce challenge in mental health and substance abuse, and having certified peer support specialists. That's why I think we should have a national certification for peer support specialists. And because we are just like any other profession, we just get to tell our lived experience, but there are 10 core functions that we have to adhere to, just like any other mental health professional. And I think when we, make sure that telehealth, that people have that, if they don't have access to transportation, that's ready, available, and also during those times when they're not in crisis, because once a crisis happens, there's a continuation of things that need to happen so the crisis don't happen again. So to your question, I think that, telehealth is needed. We talk about rural areas, that's great, but just like in cities across the state, they're needed as well. And so when we do that with peer support, I think we would see the outcome for an individual and their family that can help them get them to on their worst day, get them to their best day.
You mentioned, I liked how you put it, our system has not been built up to support the people after the 988 call. Now, on the other hand, I also like what Nick said. We can't just talk about the bad things. We have to talk about the good things. And it really sounds like, Mr. Grenier, you guys have really thought strategically how to comprehensively address everything people talked about. The community health center to treat the hepatitis C that Dr. Kleinschmidt talked about, and the housing, and the 340B to help make your margins in order to do it. How replicable is your model?
Well, thank you, Senator. I think it goes to two
Can you pull that
primary.
closer?
Sure. I think it goes to two primary focus areas that we have, placing focus on access and retention. First, with access, breaking down barriers to make sure that people can get into treatment that they need. We know very few things about addiction and recovery, but two things that we do know for sure. The first is that when an individual is seeking treatment, the harder that we make it for them to get access to treatment, the more likely that they are going to disengage and not want to go into treatment services. And so when they reach across, and if we can get them in the door and we can get them into services, speaking about addiction specifically, if we can get them in the door, then we have a much greater chance of keeping them engaged in recovery. And then the second thing that we know is that the longer people stay engaged in treatment services, the better the outcomes. And so because I like Tanja's question so much, I actually want to piggyback on something that she was talking about telehealth. I do think I agree with everything that you stated. I think it's when the treatment matches the individual level of need, you're better set up for success. But there are a lot of individuals who are not appropriate for telehealth for substance use disorder, who may not have financial wherewithal, who might just be showing up with the clothes on their back, who might not have a phone, who might not have internet access, who might not be appropriate for those outpatient group settings. So for certain individuals, as has been mentioned, you definitely want to make sure that you get them the treatment services to match their individual level of need. And it certainly is something that's scalable. I think that what Odyssey House has tried to do over the last 53 years is creatively identify where the gaps are, what is causing our individuals to not be successful in the long term, and to try to address those things comprehensively and in an integrated fashion. And I think that we do that pretty well. Bless you.
Yeah, I really do.
Oh, excuse me. You do it well. And so thank you for that. And it touches all of us. Again, Tanja said, this affects people from the curbside to the country club. Art, there's a woman in New Orleans who cares deeply about our city. And she will send pictures to me and others of the homeless passed out on a street, literally on the curbside, with a leg dangling into the street, knowing that they could be hit by a car. And we'll speak about fecal material being on this. So it degrades. So let's just say, okay, first, that person is a living tragedy. The impact upon that person's family who doesn't know where they are is a source of grief. But it impacts all of us. That's just the most visible. Greg Champagne, who is the sheriff of St. Charles Parish, says that he is the #1 provider of mental health services in St. Charles Parish. And every sheriff I speak to says the same thing of his sheriff or her sheriff, of his parish or his county. There's an occasional she, so I also want to include her parish or county. So you spoke of that Surgeon General's report. Every dollar invested in caring for patients in an effective way saves 11 throughout the system. Could you elaborate on that?
Yes, sir. Thank you for the question. I believe that somebody that you just described in the street like that, we'd have to kind of see how many times did that person actually cycle through the system and didn't actually get their exact needs met until they recycle right back on the streets. If you look at prevention, I think it's about $14 of prevention. You save $14 on prevention versus sort of treatment in situations where we can intervene. So if you address, and I mentioned opportunity costs, so addiction drives up and serious mental illness drives up the opportunity cost of somebody to contribute. And the more that that person goes through without getting the actual services that they need, the more they keep taxing the system. So I've talked to stakeholders here in New Orleans. I've been to the CCBHC in my old neighborhood of Algiers, and I talked to those people, and I've talked to the people in Mid-City New Orleans as well about these people cycling through the system. And first of all, that person that you described lying in the street is very much a redeemable person as long as we kind of get them the services they need. I also want to say that a lot is said about serious mental illness, but I want to kind of quantify that for people. What that really means, that's the government's way of saying psychotic disorders, right? So not every mental illness is going to qualify as a serious mental illness. When I say psychotic disorders, that's going to be more your spectrum of schizophrenia and bipolar 1 with psychotic features and that sort of a thing. And if you don't mind, I was a rural provider, and I've done a lot of telehealth in my career. I started off as a peer prior to becoming like a psychologist delivering sort of services. So with telehealth, to want to say, yes, it's a very effective intervention. It works just to parallel off of what Mr. Grenier said. It works really well with serious addiction once somebody's more in like an aftercare type of setting. I've been the provider of somebody at the Salvation Army where I did telehealth and provided him with the clinical sort of psychotherapy, where it's going to be a little bit of a struggle when somebody's still in active use, to where it's hard to get to that person through the screen to actually do something about themselves. Now, I actually, unfortunately, I lost a patient that way that was still using, and getting that person to actually accept a higher level of care was difficult, and I worked with his wife and family, so that was a very tragic sort of situation. But in a large respect, telehealth could be very effective, especially sort of with a lot of the mental illnesses that we sort of see. So I'm an advocate for that, but just like for all services, there is, a little bit of a gap in that. But to bring it back, I want to say the person that you described in the street is a very redeemable person. We just got to address their needs in a more appropriate sort of fashion. And the one thing I was talking about is taking a CCBHC, a Certified Community Behavioral Health Center, and establishing a link to sober residences. I think is something that's replicable. We did that with the SOAR grant, the State Opioid Response, where we put money at SAMHSA to create that link for our guys really in need, the 19 to 24 sort of patient out there. So I think that's something replicable, and we could all work on it. But I love what I'm hearing from all my colleagues today.
Stuart, you had mentioned that kind of a recurring theme is the difficulty in getting services to rural areas. But some of your facilities are in rural areas. First, how do you pull it off? And secondly, you're for profit, if you will, but you're going where there's no private. Where there's no public.
Yep.
So the public can't pull it off, but you're pulling it off as a for-profit. So will you comment on that, please?
Sure. Yeah, since its founding 20 years ago, we have been focused on the needs of underserved markets, underserved communities, and underserved patients. And I think you could sum up our mission as, we go where it's hard. We go where others haven't been. Half of the buildings we're in, at least one other company has failed, or a larger company said, this is just too hard, we're leaving. And so for us, a couple ways that we do that is and the biggest struggle we have is workforce. I mean, and I'm sure it's a theme you'll hear across this table. I have two daughters, both one studying to be a speech therapist, the other wants to go into medicine, wants to be a psychiatrist. And we've had a long talk. And part of the conversation with her, unfortunately, is, when you graduate, you'll get paid 2/3 your peers. When you graduate, you won't always be treated like you're part of the varsity staff. And I think that is something that when we think about workforce in behavioral health, rural or urban, we have to change the way we both fund, that we support.
You're speaking about both addiction and serious mental illness.
Across both. And I think so for us in rural, workforce is one of the biggest issues that we struggle with. And I think that for so many communities, they haven't had access in these communities. So I think supporting rural caregivers is so important. I would say we've talked a bit about technology. I want to continue to reiterate that, look, I think for us, it's an arrow in the quiver. It's a tool, it's an instrument. It's not an end-all be-all. Like we've talked before, speaking with a physician, whether inpatient or outpatient, is really just a part of a journey. We've got to support patients with a holistic system of care. And I think so many times in medicine, there's a lot of times we look at a cancer patient, we look at other patients, and we understand this is going to be a journey. This is going to be a long journey, and we're going to support you with all the different tools and instruments that you need for that recovery. So often in behavioral health, we say, well, we did that one thing for you, right? You're happy now, right? Or we funded this one grant. You're good now, right? Understanding that this is going to be a journey, a holistic journey for this patient and their families. I would say lastly, and we touched on this as well, in rural areas, and I can't, this is one of those granular things, is transportation. We're an inpatient setting and an outpatient setting, and I think for many of our patients during COVID, for instance, we pivoted to almost pure telemedicine. What we found was interesting was after the restrictions were lifted, the majority of our patients wanted to come back. They want to be with other people. Some chose to do their care at home or continue their care at home, but transportation for behavioral health patients is so important, and it's so broken in many states. And we can't help you unless we have an adequate way to get you to us if that's what your care needs.
So, you mentioned workforce. And when I speak to any employer in any industry, they have a problem with workforce. Mm-hmm. So let me just put on I'm a ruby red Republican hat. There's a fellow, Kylie Sparks, up in Livingston Parish, blowing and going. He is collaborating with a faith-based ministry called Lighthouse out of Church International. Mm-hmm. That takes these men, I think typically men, but I'm sure sometimes women, who have a problem with addiction. It'll give them the wraparound service that you're kind of speaking of, Lonnie. And among that wraparound service is job training. Mm-hmm. So when they finish up, they have a way to support themselves and financially. But in the meantime, they're teaching them that delayed gratification that comes from every day walking by faith, so that there's a power greater than you that helps you address these issues. And they are meeting their workforce demand in their growing business by these folks coming to them through this ministry. Mm-hmm. So much so that I was visiting with the pastor. One of the some time ago graduates of their program wrote a check for $100,000 to the ministry to support the ministry. That tells you, so when Art, you speak of that person is redeemable, there is a lot of potential in some of these folks. Mm-hmm. There is the fellow that runs the Salvation Army in Monroe, Louisiana. And he'll tell me, man, those addicts come to me and they start the story and I end the story. I tell them, I've been where you are. Don't pass me the line because I can give you the line. He was a technician for a Mercedes-Benz dealership, doing all that kind of work on high-end automobiles. And at some point fell into addiction. He says this publicly. And now he's ministering to others. So there's absolute hope. And I think that's where we need to go. You mentioned the role of faith-based. There's another faith-based I've been to called The Grove, which takes people co-diagnosed with serious mental illness and addiction. And it's a live-in facility with peer support built within. And they say, I think 70 or 80% of their graduates are in long-term sobriety and control of their mental illness, which is to say they're taking their medicines appropriately, following up with their follow-up, if you will, and they're producing in life. So, Art, you spoke of faith-based ministries. Would you just comment, and Tanja did too, and others, would you just comment upon that?
Yes, sir. Thank you. I believe faith is important. I go with the higher power concept. In a way to do that, I'm not going to just say like 12-step program, but like there is, like I made a decision to turn my will and my life over to care of God as I understood him. Sometimes when somebody comes in with an addiction, they almost turn their care and their life over to the care of heroin or the care of alcohol. So what we're trying to do with faith and enacting faith is a way to sort of see that there is something more than this actual instant gratification that's been right there. And it takes faith to actually trust the process, trust in yourself, trust in others, that if I keep doing this next right thing, if I keep working towards my goal, good things are going to happen, right? So it's a sort of a belief that I can take, and I believe nobody's come to this life empty-handed. Everybody's born with talents, ability, and resources. And addiction's like a thief. It steals those things. But if we can kind of work and instill faith to kind of keep working, we'll start to recognize these talents and abilities that we have. And also, I want to parallel a little bit off what Mr. Archer said about people sticking around his treatment center. One of the things I really like to see when I visit treatment centers is, do you have a pretty flourishing alumni community? Because I believe a lot of the people in treatment are going to be, like I'm talking about, one of the best resources that they have. To actually sort of build upon and use attraction. And that's why I actually are very fond of the peer aspect of this thing and working with Tanja and all that. So I believe some of the best resources are the alumni of people who sort of completed treatment and had actually witnessed these things and can actually, like you said, walk the walk. So I appreciate that.
Can I piggyback off what Dr. Art's saying in your question? So it's funny you mentioned both those programs. So when I talked about in my opening statement, other programs were able to look at the work we're doing and duplicate it or replicate it. So Set Free Indeed, we have 24 across the country. Our biggest one is in Wasilla, Alaska.
Speak a little bit more slowly.
Wasilla, Alaska, the biggest is called Set Free Alaska. And they have the whole crisis continuum. People always ask, well, did you sell it as a franchise? No, we didn't. We gave it away. Wish we would have, but hey, we did not. But you talk about the Lighthouse. I remember having a conversation with Pastor Mark Sturmer about when he had a vision to do that, and we had been doing that, and just gave him that blueprint of what it should look like. And now look he's doing amazing work. And also the executive director of the Grove, she came out of our program. She talked about her story. That's where she began her clean time at Free Indeed Treatment Center. So we know that faith-based organizations do work. We know that faith without works is dead. When we started our faith-based program, we got a lot of pushback because people thought that, we were just going to be pushing faith and prayer on people, which, that was their option to do so. But we were also licensed. We had evidence-based practice. We had doctors and psychiatrists and things of that nature. And, we need all of that together. A wise man once told me, screw stigma. We do recover. And there are so many people across the country who experience sobriety and recovery. And those stories are why peer support specialists and, the people that do this work, when you talked about what's working, there are a lot of people like us who do recover. I mean, I had hopes to sing on Broadway, not to be a crackhead. And I get to sit now, in front of you and these amazing folks. And so sharing that lived experience is vital. And, having that faith-based approach, give that person that hope when nobody's not there and they're by themselves, that they know that they can reach out to God or whatever their faith is in those times where they can't get telehealth, where, maybe they just need an extra push and their faith is what sustained them. It's sustainability. That's what faith is.
So a common theme here, and I want people to recognize this, is that there is an approach which is replicable, that if you put it into place, people who might currently be on the street with a foot hanging off the curb can be restored to wholeness and be a functioning member of society, not a drain upon society. paying taxes, not consuming not consuming taxes. Because each of you have spoken of coordinating the physical with the housing, with the counseling, and getting the positive results. Lonnie, you're leaning forward. It makes me think you have something to say. What is the success rate in your program of someone who's addicted, of coming out of addiction into long-term sobriety and being a contributing member of society?
Thank you. I think it's important to
Pull that
sort of-
microphone close to you,
I think
please.
it's important to sort of figure out how we view success with our efforts. Is it that we get people into treatment? Is it as I think it was Stuart who mentioned it before. Okay, we took care of that grant need. You got that money. You're okay now. It really is something where as a professional, I think 2 years in long-term recovery is a good way to measure successful outcomes. One thing that we know that's very important for someone is societal reintegration. It's something that we are mindful of when we take someone into our care, is that they will leave our care, hopefully prepared to take on the challenges associated with the world and to do so in a way that doesn't cause them to self-medicate. But that requires societal reintegration requires purpose. It requires community. It requires accountability. And those are things that take time. 28 days in a short-term residential treatment program is simply not enough. And so I think it just goes back to the importance of this topic of this hearing about a continuum of services, because it is really fundamental that you are able to address the various aspects, as you mentioned, related to someone's instability in order to help them be stable and contributing, functioning members of society in the future.
And kind of continue on the theme of if you do it, you can see results. Nick, you are involved with the crisis intervention team. I've heard from law enforcement that when they have their deputies or officers go through this, they learn how to de-escalate as opposed to escalate, that there is less, fewer shootings of people, which is traumatic for the officer if it comes to that point. Obviously not good for the person receiving. There are fewer times when an officer is tied up for 12 hours in an emergency room waiting for somebody to come evaluate the patient, because the patient is now being cared for by a professional, mental health professional, and the officer is back on the streets fighting crime. Can you speak about the improvements in recidivism and the number of violent encounters between law enforcement individuals with mental illness through the CIT you're involved with?
Thank you for that question. CIT saves lives. The creation of CIT was through a tragic incident in Tennessee where an individual with a serious mental illness was responded to by law enforcement. The family did, in fact, say that there was a mental health condition. Unfortunately, that individual was shot and killed. From there, we have seen tremendous growth in CIT throughout Louisiana. As a matter of fact, we actually have the Louisiana CIT president of a nonprofit. He's actually here today, and I am actually the vice president of that organization. And our goal and our job is to work with departments to show them the value. Law enforcement training traditionally is obviously meant to catch the bad guys, right? And we know that training and those tactics do not work in a mental health crisis. We know that escalates that. So there's a significant decrease, not only in individuals being hurt, but also in officers obviously being hurt. So there's a benefit all across the system. But there's another thing I want to touch on that I don't know that we've hit today. And we've talked a lot about individuals with mental illness, a lot about individuals with addictive disorders. We haven't talked about their families, which ties into CIT as well. Every single person in a crisis, this is a ripple effect. They have family members that need support, they need education, they need to feel like they know where to go. And one of the other aspects of CIT, and I get to ride with CIT officers, so I actually ride on the streets with some of these officers in real crises. And the comments from the family about law enforcement being the only lifeline is tremendous, but it's also troubling. Mm-hmm. The fact that mental illness is the only chronic illness where the first person you're probably going to see is someone with a badge is a problem. Mm-hmm. But To your point, yes, I definitely think, and I commend all of our law enforcement agencies, especially locally here in Jefferson, St. Tammany, and the surrounding areas, because they don't have to do this. They do it because it's the right thing to do, and they see the results, and it saves lives.
Senator Cassidy, can I say something about CIT? CIT saved my life and 2 other people in my family. The first time that law enforcement had to pick up someone I love was my mom. And that was one of the most traumatic things that happened, but it was one of the best things because it ended up, you know, that's how she ended sobriety, number one. The second person was my uncle, who was schizophrenia and bipolar. And I never forget when I was there. Matter of fact, I think out of 11 times in 1 year, I saw it 5 times, and how de-escalation and CIT training work. And the last time was myself. You know, life happens to all of us. In 2016, my husband and I was going through some things. And anyway, that was the second time that I attempted suicide. And there was 2 officers that came on the scene. One was CIT trained and one wasn't. Matter of fact, the one who was engaging with me, I trained him. And one treated me like a criminal, the other one treated me like I was in crisis. And I'm here today because CIT training does work. And like you were saying, you know, it's not just for the person, but it's for the family, and it's also for the officers who are there because it's their job. They want to protect and serve, and not do harm. But when we give them the tools they need, it works.
So I'm going to spend a little time with you, Stuart. A reality for many people is that their loved one, whether it's addiction or mental illness, is brought someplace, they're stabilized, but then the provider is not allowed to tell the family when a follow-up visit is. Not allowed to tell them key details about how to manage the disease. And the frustration I hear, maybe this has changed, but the frustration I hear from families, I'm the one who cares for them. Who do you think is going to take him there? But you won't tell me when he's supposed to be there, what medicines he's supposed to take, and when he's supposed to take them. There's just this craziness about it. Now, maybe it's changed since I had this conversation with my old high school buddy, but speak about that. And if you're watching, because when we had testimony in Congress, there was a family from New Orleans that spoke. And they spoke about how they could not be told by the provider, and their son, if I recall, ended up committing suicide, but afterwards they found all sorts of terrible things in his room, which indicated he was going to hurt other people.
Yeah.
So please speak to this.
Sure, it's a great question, and I would say we could spend probably all day talking about this topic. I mean, first of all, no one is working harder than a patient and a family in this crisis or someone in recovery to just get the life-saving treatment that they need or have the ability to help their loved one in a time of crisis. I think sometimes our lack of a national vision around mental health and substance abuse, we end up burdening other parts of society, whether it be law enforcement, schools, other settings, because we simply have not confronted, we've not funded really the things that we know as providers work every single day. You know, we get the question a lot, you know, do we know? We know the things that work. We know the evidence-based practices that'll get people back into their community, that will get them back to work. We just simply have to have the courage to challenge, I think, what are some long-standing rules, things that may sound good in academia, things that may sound good in a regulatory body, but families and providers know.
So you're speaking specifically about rules restricting the ability of a provider to speak openly about someone's condition.
Correct.
By the way, as a physician who took care of patients with, say, cirrhosis from hepatitis C, I could say to the family, listen, he needs to take this medicine 3 times a day.
Yes.
And if he ever gets confused, you need to call me, but in the meantime, start that medicine.
Yes.
You know, we could have a frank conversation, and yet that doesn't occur with mental illness. I'm not quite sure why not.
Yeah, you know, I think there, you know, I think we still have a national fear about, you know, where mental health was 50, 60, 70 years ago. I think there's a media perception of behavioral health that is really good to sell movies and books, but doesn't reflect the actual reality of what we do every day. And I think some of these rules, you know, date back to a previous time in which abuses happened or information wasn't shared, but But Chairman, you're exactly right. These rules that are in place today prohibit the adequate sharing of information with people that are going to be many times the person caring for this person, the person helping them navigate these roles. And look, I think the balance between personal rights and the family's rights are delicate issues, and they require, I think, a lot of thoughtful analysis. You know, we see this many times as states and the federal government struggles with what are the committal laws? What committal laws make sense today? And I would argue in many communities, we need to revisit that discussion. We're dooming people to lives that
Now,
they
now,
never.
for those who are not familiar with it, what do you mean by committal laws?
So in its most simplistic fashion, when a person is in the throes of a severe mental illness or an addiction disorder and they need to be compelled to treatment, they need to be brought to treatment and they can't advocate for themselves, there is the ability, the court or law enforcement, not hospitals, but law enforcement, court, members of the court can compel a patient to treatment. I think those in previous generations, there's this image of patients would go to hospitals and they would never get out. Well, frankly, my biggest struggle is keeping your loved one long enough for even the medications to even get on board. We've turned the committal laws, I would say, so far one direction, and on top of that, we've layered managed care on top of it. So the combination of those two create an environment for our most severely mentally ill where we can barely keep you long enough to get to know you before you're being pushed out of the door by many of these plans.
So I'm going to do now, before I turn it over to you folks to ask each other questions, I'm going to ask one more as a policymaker, because I am chairman of the Health, Education, Labor, and Pensions Committee, but I'm also on the Senate Finance Committee, the third person from Louisiana to serve. And that gives me a role in jurisdiction of Medicaid and Medicare, okay? And so Lonnie mentioned 28 days may not be long enough. You just mentioned it's hard to keep someone in long enough, and how there is a restriction of a total number of days on Medicare in terms of being treated. Now, I agree with you, but let's also admit that there's some that would abuse that. They would keep people in when they don't need to be in to maximize profits. And I say that because I'm a fiscal conservative, but I'm also want to take care of patients. And we know we get a great return on investment if we do it appropriately, but what we don't want is to have somebody milking the system. Now, there is a tension there, and I'm not sure that we have figured out how to have appropriateness of length of stay independently of saying you can only stay so long. Now you're speaking to Bill Cassidy, who's trying to make sure that we balance the budget, but we are able to take care of the patients who need to be cared for. Lonnie, I'll start with you, then I'll go to you, Stuart.
You know, Senator, Stewart mentioned the IMD exclusion, and I'm fairly certain that he's
So did Tanja.
Yeah, and you as well. I'm fairly certain that we're all going to be spending a lot of time
Now
talking
explain
about
what the IMD exclusion is for those who may not know.
Well, as Stewart
And
mentioned,
pull that
this-
microphone. I've had a hard time getting that microphone up to your lip, brother.
Up to mine,
I need it right
specifically.
next to your mouth. You know what I'm saying?
Specifically, the IMD exclusion goes back to LBJ, even Kennedy days, so, enacting the Social Security Administration. But essentially, what it did in relation to inpatient services is it limits the number of
Pull it a little bit
days.
closer. I cannot tell you if it's more than an inch.
You
from
won't
your
hear me
lips.
back there. It limits the number of days that an individual can receive inpatient services to 15 days, and it limits the bed capacity that a provider can offer services
So we have
to
a shortage
16
of beds, but there's federal Medicaid rules which limit somebody providing care to only 15 beds, correct?
Yes, and those are longstanding rules. However, each state has the option to have a waiver around the IMD exclusion. Louisiana is one of the states that does have a substance use disorder 1115 waiver. So it allows for our treatment providers to help individuals past 15 days and expand beyond 16 beds. However, we don't have a 1115 waiver for serious mental illness. And so that could potentially be something that could allow for individuals to receive inpatient psychiatric stabilization beyond 15 days.
Okay, let me stop you. That's beyond
that's for-
15
that's
days
for mental
because
health.
just because you'd have more beds by which to keep somebody in.
Well, exactly. Well, not only that, but we need longer lengths of stay specifically for serious mental illness.
So help me out here. Going back to wearing my fiscal conservative hat with my we got to take care of patients hat because we get $11 to $14 return on investment.
Right.
How do you make sure that the increased length of stay is not being milked by bad actors, but rather is truly appropriate care? You with me?
Absolutely. I would say that there's certainly merit to that. However, I would also submit that the value of treating individuals and making sure that they get the individualized level of care that they need for as long as they need may certainly outweigh any potential fraud or mismanagement associated with that. There's also something to consider where we might uniform prior authorization windows so that we're not piecemealing for a day here, 5 days here, but rather maybe individuals could be authorized for 28 days at a time in treatment. There are certainly, different ways that we could go about it, but it's simply the case that minimum length of stay, according to the American Society of Addiction Medicine, should be 90 days. But managed care, as has been stated, once you start laying things together and trying to figure out what you're going to pay for, 28 days is where we've landed.
Stuart?
Yeah, I would say, look, a certain amount of friction in the system is probably healthy. I'll acknowledge that between providers and payers. So I think that's healthy. I would say, a couple things. As we embrace more outpatient care, we have to recognize who is an inpatient now in the hospitals. They're increasingly the more severely mentally ill. And then you have this fentanyl crisis that we all know about, and you now are facing, and we're seeing in our hospitals, a more higher acuity behavioral health patient than we've really ever seen before. Patients that are in more crisis, that could be more violent, that have a lot of issues. And so I would say, look, I think there is a certain amount of friction that's healthy. I would say your average behavioral health provider is not equipped to go to battle with these payers. These are multi-billion-dollar organizations with all kind of technology, and you have providers that, for instance, will admit a patient and we'll get a prior approval to admit the patient. After 3 days, every 24 hours, the payer wants me to, recertify why the patient has to be there. It's simply harassment. And so again, I think that for us, we're arguing over keeping you long enough to hopefully keep you alive, much less transition you to outpatient treatment. I think that when you look at the margins of the average providers in this space, and you look at the margins of the average payer, I think that tells you a lot of what you need to know. And I think our patients, frankly, and our families are easy to pick on. When you're on the medicine side, you have a broken leg, you're on a ventilator. The first half of my career was on the medical side in the severely mentally ill. I think on ours, we are working with families. We're working with some things that the payers view is subjective. They're not. And I think there's evidence-based criteria that proves out the treatments that all of us engage in every day. That's not to say there aren't bad actors, but there's bad actors everywhere. I think you see them in every aspect of healthcare, and they need to be pushed out of the program. And so I think, look, I do think that for behavioral health providers, we are uniquely vulnerable, I think, to some of the things that are in the industry today, and some of the challenges that our patients face.
Art, you've been both a provider and an administrator through SAMHSA, so I'm sure you've thought about this. I'd like your perspective, please.
Thank you. Yeah, I believe in repealing the IMD. As a fiscal conservative, as you said, it's going to be very expensive. So the one thing I'm looking at with the IMD, and like your example with the lady with the leg in the street, is that we could do that for people with serious mental illness, people that are on the way off on the psychotic sort of realm of the spectrum. We could expand the IMD to include more of them so they don't keep recycling back to the street. And I think that would be sort of an effective way to do this. I also sort of want to say that as a provider, I've worked in there, and so I've seen it. basically, when somebody comes in treatment, you do the assessment, right? So since that's not 100% concrete as like you as a physician, there's a lot of gray area in there. So you could always put somebody in your treatment program if you want. But the thing to do is to actually sort of have an honest assessment to where treatment matches the needs of the individual. And that's the way you get the best success rate. As treatment matches their needs, addresses their liabilities as well as their strengths to get them back into being self-sufficient as quick as possible. That's why I like what Odyssey House is saying here about like stepping down levels of care. So we could do this as a crisis intervention. We could stabilize people based on their need. And you could stabilize people who are in a psychosis, get them the help they need, and you could sort of step them down to where they're getting all their needs met at the precise time of their recovery that they're working and getting them into self-sufficiency.
And so that would actually justify a regular follow-up from the managed care provider, not the hassle, but to make sure they're being appropriately stepped down. But what the insight you're giving is that if your initial diagnosis is correlated with the need for longer-term care, as opposed to someone with mild situational depression,
Right.
who would be easy to care for, but you certainly don't want them to stay in for 28 days. That would be milking the system. No, you want somebody who's schizophrenic.
Correct. You want to address, with the IMD, you want to make sure we hit our most vulnerable people, our people in need, like the lady that you described. So that's what we would want to do with the sort of the IMD, address that. And you can also like include severe substance use disorders where people don't understand how perilous close they are to fatality, right? So many people, it might seem obvious to the guy outside of them, but to them inside their bubble of addiction, they don't see how perilously close they are to sort of fatality. So I think if we can kind of design the system to hit those really chronic, severe people, we can address their needs without, like you said, as a fiscal conservative, without just opening the door for everybody, like you said, like somebody with like mild depression or something like that.
And to that end, I mean, what we're seeing, I think,
And
more
by the way, let me
likely.
interrupt you a second. After this, I'm going to ask you to ask questions of each other. So just be thinking as Lonnie speaks about what you would ask of each other, because I'm going to learn, or we will learn a lot from that. Please.
Sure. I think to that end, what we see in a treatment environment more than the opportunity for fraud and abuse is the managed care organization simply not giving us the time and authorizing the time that we need with our clients. A lot of times, what we find is the patient case reviewers are simply not qualified to be able to provide the judgment that they are, especially considering when our clinicians are qualified, are engaging with the client, know them, can be able to make a medical recommendation, yet the managed care organizations, because of cost containment, are actually recommending lower levels of care than what is being recommended by the provider. That's what we see far often than not, is actually not being authorized the time that we need with the clients that we serve.
If you have on a later off the record, if you have a way that the government could regulate that, because I'm not quite sure how we'd regulate that, because I hear that from doctors treating medical illnesses, that the person who is reviewing the prior authorization is not competent to review. Now, that may be a perspective, but still you hear it. And so, Nick, why don't you start off our questions of one another? And it can be of me too, but I think,
Sure.
whatever.
Thank you. So I don't know if it's a question so much as a question to everyone on the panel. And I'm going to oversimplify this whole conversation that we're having about inpatient care and about continuum of care. When I started in this industry, obviously, the Medicaid, as it pertains to serious mental illness, that's what I'm speaking to, and not addictive disorders. As it pertains to serious mental illness, we've seen a dramatic increase in access to medications that allow people to lead fulfilled lives. We're seeing a lot of improvements. But what I see out of the inpatient system, so this is kind of a question definitely directed at you a little bit, but directed at everybody, is the way that people navigate this system. Our inpatient and residential mental health facilities have become nothing more than we will stop you from harming yourself or others. They're not set up, and it's not against them. It has to do with a lot of factors. But as I see it, they're just there to stop death. And philosophically, as a society, is that really what we want that part of our healthcare system to do? They once were there to actually treat, yes, to stop harm and death, but also to get people onto the path of recovery. At this point, because of how quickly people are discharged, our inpatient psychiatric facilities are simply there to stop an individual from harming themselves, from harming others, and that is it. And
Stuart?
so as a systematic problem, I think that's an issue. I don't know that.
Yeah, look, I would, believe that our care is a lot more comprehensive than that, for sure. And I think, and we have an open formulary, right? So whatever the doc prescribes, the patient gets. But I don't disagree with the fact that our biggest struggle is just, almost from day one, we're under attack by the payers. And I think we're, many times it may take us, a bit of time just to ascertain what's going on with this patient. They have a very nebulous history. We're trying to navigate a family situation. And by the time that's kind of becoming more clear, we have a payer banging on the door trying to get the patient out. And many times maybe recommending a level of care that they themselves don't fund afterwards. That's another big issue that we have as we think about Medicaid in many states. We work very closely and we provide IOP and PHP services for folks these folks know it well. These are step-down levels of care. They're fundamental to what we do and for what a lot of these providers do, but they're not always funded by Medicaid. Those are not things that are uniformly funded in different states. And so I think just as important about the length of stay in inpatient is to your point, where are you headed next? Is that funded?
Art, you had something?
Oh, yeah, I'd like to piggyback off Mr. Richard there. From my clinical experience, when you're looking at serious mental illness, and I worked at treatment centers with severe overdoses, multiple 10, and a lot of co-occurring. But numerous times I would get somebody with a more acute problem as their serious mental illness. So you could stabilize them in treatment and kind of get them going. But what I've noticed is out there, the gap that I see sort of like in the treatment community, the continuum in that is, where do you place these people with serious mental illness post sort of that treatment stabilization period, right? So that's an area where the gap, I think that we would sort of need to kind of close. And like when I was at SAMHSA, the idea that I was thinking, because CCBHCs provide SUD and mental health and crisis care, is a way to kind of have that, to sort of fortify that was sort of like with a recovery house situation, to where they could receive services and have maybe a step-down level of care as they get more ingrained to go into society, like Odyssey House, Mr. Grenier was talking about, the resocialization of it all. So there is that need for that piece for people with serious mental illness. Now, they will have places to place them, but it's kind of out of reach for people with third-party sort of payers, right? So a lot of Medicaid in that is hard to find that funding for that sort of level of care. But it is a gap that I do feel like we need to sort of address here as a community.
Does anyone else have a question for the others?
I just wanted to, I know I already talked, but I just wanted to wholeheartedly agree with that. I've spent a lot of my career, time, and energy creating housing programs for people with severe and persistent mental illness. And the only way to leverage funding for that is generally local funding. This is not something, and it's one of the greatest needs that we have. So I will tell you this, if you have anybody in this region, we do actually house individuals.
Oh, great.
And are building a tiny home village actually in St. Tammany Parish right now, specifically for people with serious mental illness. So if I were to be asked what my number one priority is, 1, 2, and 3, is for supportive housing for people with severe and persistent mental illness.
Yes, I agree with him. That's
And
great.
you're specifically speaking of severe persistent mental illness.
Yes, sir.
Yeah.
So I guess I have a question for everyone and just a comment. So we've talked a lot about, folks with SMI and, even, those who are homeless. But I know you're talking about this being live stream, and just if the average American is watching and listening, crisis is not cookie cutter. It can happen to anyone. And I have been fortunate to work with people who are broke or who have billions. And I know that one thing that happens when you're in crisis, sometimes none of that matters. So since we're talking about a crisis continuum here. And so how do we address it as a whole for just the average American who life is happening, they find themselves in a crisis, what do they need to do? Because I've had to navigate people who have insurance, who have means and those who don't. And to be honest, the challenges are the same. And so when we're talking about a robust crisis continuum, we have to make sure that we're talking about meeting the needs of Americans no matter where they are, no matter what zip code or state that they live in, that they know that there's help and there's hope and that crisis is real. And when we talk about that, first of all, thank you for having this, because May is Mental Health Awareness Month. And, 988 was one of the best things in a long time. I never thought I'd live to see something like 988 in my life. And I think that when we talk about 988, we have to push it more to let people know that anyone can call it 24 hours, 7 days a week. That also, it's not just for a person, because a lot of times people think it was for people who just have mental illness, but it's also for someone who's experiencing a substance abuse challenge. So I guess my question to you guys is, when we talk about the crisis continuum, how do we make sure that everybody, no matter who you are, if your crisis is serious mental illness, or if it's just that you just got a divorce, or you just found out someone died in your family and you find yourself in a crisis, how do we make sure that we let the average American know that you matter, that what it is that they need to do, because we think people do and they don't know how to even enter a crisis continuum?
I'll just say, making our society better is a team sport. The person that says, my vote's only one vote, know that one vote can make a difference. And the person who says, if I tell you 988 is a call you can make if you're having problems, the one person you tell may be the person who tells many others, or maybe the person who needs it. Just my perspective is do whatever you can, whenever you can, as much as you can to help other people. Anyone else want to comment?
No, I mean, I would echo this sentiment. And look, I would first say, Senator Cassidy, how appreciative I am, and I know my colleagues are, to have this discussion with you in this forum. It speaks a lot to the dedication you've had to this space, and we just really appreciate the time you've given us to talk about this. Look, I am a little bit encouraged. When I look at my kids, I see an awareness in them. They talk about this at school. Their peers talk about this. I think they're more open in many ways to this. I think it's maybe my generation and others that still have the problem to talk about it, or have the fear of doing this. I think the more we can do to normalize this, the more we can share our own stories. Most people I've met in behavioral health or substance abuse have a personal journey. And certainly whether they're comfortable sharing it or not, it's up to them. But I do think the more we can normalize this, the more we can share these stories that, hey, look, you're no different than me, and that person's no different than us. I think, historically we wanted to marginalize, I think, many of these communities, or walk past that person in the street, but that's our brother and our sister in many ways. And so I think, again, in any way that we can share our stories and that we can make access easy, I think that's the final piece I would share. Is like, many times, because I get those same phone calls as well, like, nobody's trying harder to get help than a patient in crisis. And we've got to make these pathways easy, and they don't always lead through a physician. We've got to find ways where we can arm primary care more and more, and equip them and reimburse them for the time they spend with patients and families. I think faith plays a huge role in many of our lives, coming up with and equipping places of faith to have these conversations. And I think the concept, it gets said many times, of no wrong door. We've got to have that mindset that folks can enter care and ask for help in really many different ways, and they're all okay.
I thank you all for participating. It's been a really good panel. And I took notes from things that I've learned. By the way, I've learned from each of you through the course of time. I ran into your predecessor, I think his name was Ed, way back when on an airplane. And when I first became acquainted with the Odyssey House, as an example. And y'all are obviously doing a fantastic job. What am I taking from it? Mr. Richard saying 1, 2, and 3 is housing. And Dr. Kleinschmidt speaking about how maybe we could do some sort of limitation, fiscal conservative, we got to take care of you by the initial screening of the diagnosis. The fact that, Stuart, your group has successfully brought programs into the rural areas tells me it can be done, because you also have workforce development in there. But payment policy is key. We got to get the payment policy right. Odyssey House putting successfully that wraparound set of services that then gives someone a trajectory to wholeness. And Tanja, you always, through your personal testimony of your life, but also of others reproducing what you are doing. Oh, how did you do it? We're going to do it. And now one of their graduates is given $100,000 back to the program to help others. I mean, that reproducibility, things work, you can put it in your community, I think is one of the messages that each of you had and that we have to emphasize coming out of this. So thank you all for participating. I have some, see if I get this right. For any senator who wishes to submit a question for the record, you have up to 10 working days to do so. And with that, I bring to an end this hearing. Thank you.
Thank you.